your test. So what is telling you here is like if you use these letters, pneumonia, and use COPD. So you in pneumonia is dull. So you are going to, when you do percussion, you are going to have a dull percussion. Okay. But in COPD, if you do percussion P, you are going to have hyperresonance. Hyperresonance. Then another important thing here is your I. This letter I. I. Okay. In pneumonia, I is increased. Just use the letter I. So the tighter fremitus and the egophony will be increased. I already explained what is tighter fremitus. I already explained all those things. If you remember what I explained in the normal finding, your tighter fremitus, we say that E is egophony. You tell the person to say E. If they say bar, then there is a problem. Then tighter fremitus is tighter touch. Touch. You are feeling it. When you touch their back, when they are saying 99, 99, you will feel the vibration. That is tighter fremitus. But whispered pectolaricum is you will tell the patient to whisper. So those are the two ways to remember tighter and whispered. Whispered has to do with what you hear. So when you tell the patient to whisper 99, when the person have a problem like COPD or pneumonia, it's going to sound muffled. That is the abnormal finding. So what we are saying here is under pneumonia, the tighter fremitus and egophony will be increased. So use I, letter I, as increased. But the COPD use D as decreased.
mm,
Decreased. So the tighter fremitus is going to be what? Decreased. The tighter fremitus and the egophony. The tighter fremitus and egophony will be decreased. Decreased. So D for decreased. P for hyperresonance in COPD. But pneumonia, U for dull percussion. I for tighter fremitus and egophony increased. Then when you come down again, we have two conditions in COPD. Remember, COPD is the umbrella word. And in COPD, you have we call it the emphysema and the chronic bronchitis. These two conditions. That is your COPD. So in bronchitis, you can see these two pictures and compare. You see in bronchitis, the bronchus, there is narrowing of the bronchus because of what? Excessive mucus. Everything you can see how this pipe, we call it pipe, right? Airway, where the airway is supposed to flow. It is narrowed because of mucus. So these people, we call them, if we go back to what we are talking about, we call them the blue bloaters. So remember, B for B, they are the blue bloaters. B for B, blue bloaters. Then we have the emphysema. The emphysema, their problem is that the alveolar, which is those tiny airway air sac, the air sac, it is damaged. You can see how it is damaged, and when it becomes damaged, there is loss of elasticity. So a patient will start having shortness of breath. Um, but one thing you need to know for in the exam is that they are going to have what we call barial chest because these people are finding it difficult to breathe. They are going to have weight loss. When they are tired, they cannot eat. Because they cannot eat, they are not gaining weight. And that is why we call them P for pink buffer. In the exam, when they ask you a question, under COPD, which group are the blue bloaters, that is bronchitis, which group are the pink buffers, that is the emphysema. And another thing to remember in this emphysema is that they are going to have a flattened diaphragm and increased anterior posterior diameter. So how I always explain these two conditions is like, for blue bloaters, when sputum is building up, the sputum is building up, building up, building up, it's going to block this airway where the airway supposed to be going in, and it's going to make the smooth muscles to become hypertrophied, or hypertrophy of the smooth muscle. Then there is excess mucus. When there is excess mucus, that is why in COPD you always hear that sputum production. They have that production of sputum. So it covers the whole thing. The air is not able to go in freely. It's not able to go in freely. That is the bronchitis. Okay. But in emphysema, think about emphysema as a balloon. If you get a balloon is small when you get it. When you start blowing air inside the balloon, blowing air, you keep blowing, blowing, you are making the balloon to lose elasticity. It's going to lose the elasticity. And when it loses the elasticity, you are going to see that if you measure the balloon from the first time you had the balloon and now you have blown a lot of air inside the balloon, there is going to be an increased posterior anterior diameter. That is very high yield in the exam. They are going to ask you, is this increased? Is this decreased? It is increased. And it is going to be more flattened. Okay. And when that balloon bursts, you are going to hear a loud sound. That is hyper resonance. That is just a simple way I like to remember it. So then this brings us to the treatment of the COPD.